Okay, so this is new presentation. This is a chest radiograph of an 45 years old male with history of smoking. There is bilateral symmetrical interstitial thickening. There is some nodules, and if we zoom, we can see those nodules here and here, and maybe some tiny cystic changes. These changes are involving the middle and upper zones. There is no pleural effusion, no lung cavitation or masses. Cardiac size is normal, no bone pathology. So in conclusion, there is bilateral symmetrical reticulonodular pattern with some cystic changes. In case of young smoker male, my primary diagnosis is Langerhans cell histiocytosis, LCH. And my differential diagnosis will be lymphangioliomatosis, but it's less likely in this case as it is exclusively in female patients. Other differential diagnoses will include pneumocystic pneumonia if he is immunocompromised patient. It can be lymphocytic interstitial pneumonia. So to take this further, I would like to check the previous chest X-ray, and I will refer the patient to chest clinic. Also, I will arrange HRCT for better evaluation. Here the presentation is finished, and you may be shown a CT for the patient. Now let us see some differential diagnosis of cystic lung disease. And because there is a wide range of pathologies that cause the lung cyst, the simple way to make the diagnosis is to characterize the cyst according to the distribution. If it is upper lobe predominance, if it is diffuse, or lower lobe predominance. And after we identify the distribution, we have to look for other associated findings. So the example of the upper lobe predominant cystic lung disease is LCH, as it was our case. Usually occur in young male with history of smoking. And actually the LCH will start as nodularity, mainly centrilobular and peribronchovascular, as in this case. Then as the disease progresses, the nodules start to cavitate, forming small thin-walled cysts. And later on, the cystic change become more prominent, as we can see here, more obvious, thin-walled cysts with typically bizarre shapes. And because LCH is smoking related, so we can identify some centrilobular emphysema, as in this case. We can see this cyst with centrilobular structures here, here, and here. So those are centrilobular emphysematous change associated with LCH. And we can see also biliary disease. Later on, the LCH can progress to lung fibrosis and honeycombing. The next category is diffusely distributed pulmonary cysts. And the example for it is pulmonary lymphangiomatosis, and is exclusively occur in young female. The cysts are usually thin-walled and diffusely distributed. As we can see in this coronal image, the cysts are in the lower as well as in the upper lobes. And the lung in between appear normal, no nodularity and no ground glass. If there is presence of pleural effusion, which is simply indicating chylothorax in a cystic lung, this makes the diagnosis of LAM more simple. And as we know that LAM can be sporadic and it can be associated with tuberous sclerosis. So if we can take a look on the upper abdomen looking for kidney lesions, as we can see in this case, there is multiple bilateral fatty lesions that are representing angiomyolipomas in a patient with tuberous sclerosis and pulmonary lymphangiomatosis. Now let us see the differential diagnosis of lower lobe predominance cystic pulmonary disease. The first and most important differential diagnosis is lymphocytic interstitial pneumonia, which usually occur in patients with Sjogren disease. And as we can see here, beside the scattered thin-walled cysts, there will be ground glass opacity and some nodularity. Also, maybe there is mediastinal lymphadenopathy. And because there is a risk of developing lymphoma in a patient with LIP, the presence of persistent consolidation may be suspicious in those patients. The next differential diagnosis of lower lobe cyst is Birt-Hogg-Dubé syndrome, which is an autosomal dominant disease, and it's actually a triad. Consists of lung cysts, which predominantly lower lobe, as we can see in this sagittal image, as well as skin lesions and renal lesions, which can be renal cell carcinomas. The third differential diagnosis is pneumocystic pneumonia. Typically, the patient is immunocompromised, and it's actually middle zone distribution. It principally consists of ground glass opacity and interstitial thickening, and the presence of some cysts indicating pneumatocoel. And typically, there will be no pleural effusion and no lymphadenopathy. The last differential diagnosis of lower lobe predominant cystic disease is pulmonary neurofibromatosis. As you can see in this case, the patient has lung cysts and can be associated with ground glass opacity or Bullary disease. And the key finding in those cases, as in this patient, is the presence of subcutaneous nodules here and here. So the presence of other finding related to neurofibromatosis make the diagnosis easy. Like in this case, the presence of subcutaneous nodules, or the presence of paraspinal neurofibromatosis, or bony pathology like scoliosis or rib hypoplasia. Now, finally, to recap what we have discussed, in a cystic pulmonary disease, first of all, look for the distribution of the cysts. Are they upper lobe or diffuse or in the lower lobe? Look for the cyst morphology. If the cysts are thin-walled or thick-walled, bizarre shape, look for associated city finding that may indicating specific disease, like the presence of ground glass opacity may indicate the lymphocytic interstitial pneumonia or pneumocystic pneumonia in immunocompromised patients. The presence of nodules may indicating lymphocytic interstitial pneumonia, and the presence of emphysema that may indicating LCH or any other air trapping disease. And also be careful of patient history. If he has connective tissue disease, HIV, neurofibromatosis, or tuberous sclerosis. And look for extrapulmonary findings that may indicate specific disease, like the presence of chylothorax, presence of renal lesions, lymphadenopathy, or skin lesions. Lastly, I would like to share with you this cystic lung diseases, which looks in CT similar but are completely different pathologies. Let us zoom a little bit. So as we can see, this cyst has a thin wall. It completely air-filled, some of them peripheral nodules. Those cysts has no wall and has some central dots. Those are representing lung cysts in a patient with lymphangiomatosis, and the cysts are typically thin-walled with completely air inside. The peripheral dots are simply pulmonary vascularity. This is a smoker patient with centrilobular emphysema. The centrilobular emphysema usually has no wall and contains what we call centrilobular structure, the central dots. So be careful to differentiate those both pathologies. Here the presentation is finished. I hope it was helpful, and thank you for watching.